Hello everyone. So let's continue with tetralogy of Fallot. So let me start the timer. Yes. So in the last video we covered the definition, but let me go through the definition again. So briefly, yeah. So what does it? What does that mean? Tetralogy meaning consisting of 4 components. So what are those? Ventricular septal defect. So it is a large defect which is between the ventricular which is in the ventricular septum and which connects the left and right ventricle. Then there is pulmonary stenosis. Pulmonary stenosis, it is the right ventricular outflow tract. So whatever comes out of the right ventricle, so normally it comes out through the pulmonary vessels, pulmonary artery, right? So in this particular condition, the pulmonary artery is stenosed, and then there is overriding of aorta, which what it means is the aorta is over the ventricular septal defect, and the blood from both right and as well as the left ventricles, it enters into the aorta, and then there is right ventricular hypertrophy. Let me check if the mic is on. Yes, yeah. Then there is right ventricular hypertrophy. So this is a compensatory mechanism. So you have seen, we know that there is pulmonary stenosis, which means that there is you need a lot of pressure to pump into the pulmonary vessels, and that is the only outflow tract. And the other one, which is ventricular septal defect. So what happens is, if you want to push the blood out of the right ventricle, you need to generate a lot of force. So because of that, there is right ventricular hypertrophy. So what is the hemodynamics of this condition? Let us go through that. The degree of cyanosis depends on the severity of pulmonary stenosis. So that is what I just said. So right now, so cyanosis, what does it mean? So deoxygenated blood in the periphery. So how does that happen? So we'll go through this first, then I'll talk about it entirely. If the pulmonary stenosis is severe, right to left shunting occurs through the VSD, causing systemic desaturation and cyanosis. Increased right ventricular pressure leads to hypertrophy and compensatory mechanisms like collateral circulation. So we already know that the right ventricular outflow tract is narrow. So now what is the other way for the right ventriculars to send out the blood? That is this septal defect. So let me pull up a picture over here. So VSD. So what happens is, so since this thing is not VSD, sorry, TOF. So what happens is, so this is blocked, this is very narrow. So what happens is, the right ventricle has to send the blood somewhere. So it sends it out through the left ventricle. So this is the gap, it enters the left ventricle, and then the aorta, which is overriding both of these, it contains both the mixed blood, and the mixed blood goes out. Now the mixed blood, it is coming from this also, and because of this deoxygenated blood, there is peripheral cyanosis. That is what it means. And hypertrophy, I have already mentioned what the mechanism is. Clinical features, cyanosis, as I mentioned earlier, and it worsens with exertion. So then there is clubbing. Clubbing is because of chronic hypoxia. So we know that clubbing, one of the theory of clubbing is the theory of chronic hypoxia. So that leads to increase in PDGF and transforming growth factor beta, and also the heart murmur. So harsh ejection systolic murmur at the left upper sternal border due to RVOT obstruction. So let's dissect it nicely. So harsh ejection systolic murmur. So ejection systolic murmur means whenever the ventricles are in ejection systolic state, there is murmur. So which area? Left upper sternal border. So left upper sternal, what is present over there? There is, it is the pulmonic area. So what do we know already? Pulmonic area has stenosis. So whenever blood flows through this stenotic region, there is turbulence, and that causes, and that happens only during this one, what is it, systolic phase. So, that is why we have harsh ejection during the ejection phase, systolic movement at the pulmonic region. Then there is something called as TET spells, cyanotic spells, a sudden episode of worsening of cyanosis due to infundibular spasm leading to right to left shunting. So, we already know that whenever you are exercising a lot and all that, your peripheral resistance reduces, so that the so that the heart delivers enough amount of blood. So, but what happens in that particular case, already we know that deoxygenated blood can't get into the lungs because the pulmonic wall, the pulmonic region is stenosed, pulmonary artery is stenosed. So, then what happens, lots of blood goes from this, it is already contractility and everything is high. So, everything is getting pushed over here and the peripheral vasodilation is also helping it. So, lots of blood moving into the aorta and the peripheral region. So, what are the, then the squatting position. What does squatting position help in? It helps in increasing the systemic vascular resistance. So, what happens? So, whenever the systemic vascular resistance increases, you have lot of pressure in the lot of pressure is required by the left ventricle to push out blood. So, if more pressure is required on this side compared to this right ventricle, left ventricle will have comparatively more pressure. So, then what happens? This thing can't push a lot of blood into this. So, because of that, cyanosis improves whenever there is peripheral vascular increase in peripheral vascular resistance. So, whenever PVR increases, lots of pressure is required from here to push out this, and this thing goes away. It does not let a lot of blood into this. So, squatting helps in that sense. And then there is then there are different investigations which could be done. First one being ECG, where there is, which shows right axis deviation. As we all know, we have discussed it earlier how it works. Whenever there is hypertrophy, the axis deviation happens in that side. So, chest X-ray, classic boot shaped heart. So, due to RVH. So, TOF, boot shaped heart. Let us see how it looks like. So, this is how it looks like, very nice. And then echocardiography, it is for to visualize the anatomy. So, you can look at the VSD, where it is, or the sizes, where the pulmonary stenosis is, exactly what the site is, and the overriding aorta. And then cardiac catheterization, used in complex cases to assess pulmonary vasculature and coronary anatomy. So, catheterization, it is mainly done for the vessels. So, you check out what the vessel status is, the pressure and all that. Next, coming to the treatment. So, the treatment, the thing is, we already have the entire TOF, meaning the special part of TOF, that is the cyanotic spells, in a different section, and over there we are going into the treatment aspect also again. So, here you can see there is management of cyanotic spells, which is given again. So, keeping that in mind, let us learn this general management overall. So, cyanotic spell management, okay, that comes first. So, knee chest position, let us see how it looks like. So, knee chest position, let us see TOF. So, this is how it is. So, this, in case of TET spells, if you do this, PVR increases, reduces systemic venosity, increases systemic vascular resistance, decreasing right to left shunting. So, we already know how it works. Oxygen therapy increases arterial oxygen saturation, reduces pulmonary vascular resistance. We already know that cyanosis occurs in general in this particular case. So, what do? We give more of oxygen. Morphine sulfate suppresses hyperapnea and decreases oxygen demand. So, in this particular case, let us see how it works. So, let us see in case of TOF. Morphine sulfate used for by suppressing hyperapnea, rapid deep breathing, this is suppressed. This helps to reduce the respiratory drive time and further decreases the SVR, which can worsen the right to left shunting. So whenever there is hyperapnea, there is decrease in SVR, decreasing oxygen demand by calming the patient. Okay, this one makes sense. And vasodilation, minor effect and primary may contribute to systemic vasodilation, but improving pulmonary flow. But this is not we are looking at. We want to know what this means. So let's see what this means. Meaning. So hyperapnea means rapid and deep breathing. In TOF, a child experiencing that spell breathes faster and deeper because of body is not getting enough of this oxygen. So what happens when a child breathes too fast or too deep? It lowers the SVR. When the child breathes deeply, the blood vessels in the body relax and this worsens the right to left shunt. We know it already. How does this help? Yes, exactly. We need to know that. Suppresses hyperapnea. Oh, okay. So this reduces the okay. So we already know that opioids. So in case we take the in exaggerated sense, when you have opioid overdose, what happens? You breathe less. So similarly, in normal dose also, it reduces breathing, deep breathing. So like that it helps. So let's copy this and save it somewhere so that anybody can reference this at a future date. But we need to close the rest of them, otherwise the computer might start lagging. Yeah, so this is PEDS 5. Yeah, so then coming to propranolol. So we understood what the morphine sulfate, why do we use that. Propranolol, it is beta blocker, reduces infundibular spasm and systemic vascular resistance fluctuations. So reduces infundibular spasm. So infundibulum, we need to also know this, infundibular spasm. What about this? So it is a beta blocker, blocks the adrenaline of the heart on the heart effects of those. The part of right into the pulmonary, into this area can spasm. Yes, we already know. Yes. So it reduces. Okay, it was very simple. It reduces spasm of that particular RVOT, right ventricular outflow tract. Stabilize the blood pressure, prevent sudden drops in SVR that could worsen the right to left shunting. Okay. IV and bicarbonate therapy corrects acidosis, improves systemic perfusion. So we already know that lots of hypoxia is happening, and that is a predisposing condition for metabolic acidosis. And coming to the surgical management, we have certain repairs, definitive repair, complete correction. So performed 6 to 12 months, key number 6 to 12, that is almost a year, infant. So involves patch closure of VHD and widening of RVOT, and so you close the patch. So where is it? Yeah, so just for us to remember it more easily, close the patch, widen this, close the patch, widen this, and that is the definitive repair. And there is something called as Blalock Taussig shunt, which is palliative surgery performed in neonates with severe cyanosis. So just knowing the name should be good enough, I feel. Connects the subclavian artery to the pulmonary. Let's see how it looks like. So we have the modified. Yeah, so some vessels are being connected. So what are those vessels? Subclavian artery to the pulmonary artery to increase the pulmonary blood flow before definitive repair. So the pulmonary subclavian artery is a oxygenated region, and it is connected to the pulmonary artery, which is the deoxygenated region, and because of this, overall there is more blood going to the lungs. So that seems to be the only logic behind this, and that is done before definitive repair. So this is the definitive repair, and there are other ways of doing things like pot shunt, Watterson shunts, and these seem to be the newer techniques, but we just need to know the names. That's what I feel. But if you want, you can go in more detail, because in the Arun Babu textbook we just had these particular points, this is added separately. Added these separately. Then coming to the complications, hypoxic spells, squatting episodes. So this becomes very common, and cerebral abscesses due to paradoxical embolism. So what is paradoxical embolism? So we already know that the venous system empties into the right side of the heart, the right heart, and then it can go into the pulmonary circuit. But whenever there are shunts, what happens? The shunts cause these emboli to enter into the left heart from the right heart. And where does the left heart drain? So what does the left heart supply to? Supplies the brain and all those places. So because of that, that is the paradoxical shunt all about. Then and brain, and then there is strokes and all kinds of features. And cerebral abscess is one of the components of this one, not components, one of the complications. Polycythemia due to, I realized I make a lot of grammatical errors when I'm teaching. This I got to know when I reviewed one of the latest videos. So I'll make sure that I don't commit such errors. Yeah, that was it. Polycythemia due to chronic hypoxia. So polycythemia is a compensatory this thing, and congestive cardiac failure if not treated properly, if not treated. So that is in general. Then now coming to TET spells proper. So this is a very important question. It's a hallmark of TOF, sudden increase in right to left shunting. So right to left because there is spasm. Yeah, it could be because of spasm leading to profound hypoxia and cyanosis. Occurrence most commonly seen in infants with TOF, particularly 2 to 4 months. Or 2 to 4 months. Typically triggered by crying, feeding, defecation, exertion. Crying, feeding, these things often occur in morning hours after waking up. Symptoms: sudden onset of deep cyanosis. Where do we see those? Lips, tongue, nail beds, they turn bluish. Hyperapnea, rapid breathing due to severe hypoxia. The child breathes fast and deeply. So what can we do for this? We already learned that. Morphine sulfate, yes. Irritability and restlessness due to hypoxia, cerebral hypoxia, gasping respiration. Severe spells may lead to gasping or even apnea. Loss of consciousness due to severe and prolonged severe episodes, yes, affecting the, so we can see repeatedly it's affecting the brain. Again, convulsions or stroke due to prolonged cerebral hypoxia. So cerebral features, a lot of them. Squatting position, the child instinctively squats to relieve the spell by increasing the systemic vascular resistance. So what is the mechanism? Increase in the obstruction, RVOT, reduces the pulmonary blood flow. Increase in right to left shunting across VST. We already know how this works, so I am just reading it out. Deoxygenated blood enters the systemic circulation, yes. Sudden fall in systemic vascular resistance and worsening of right to left shunt, and then there is systemic hypoxia and acidosis because of so much of deoxygenated blood, so much of it. Trigger respiratory drive, increasing the cycle, yes. Last part, respiratory cycle. So more of, yeah, you don't want a lot of this thing to happen. What is that? Hyperapnea. You don't want deep breathing. Next, coming to the management of cyanotic spells. Aims of treatment: reduce the shunting, which is right to left, increase the systemic vascular resistance, decrease the respiratory distress and metabolic acidosis, improve the pulmonary blood flow. Some of this we have already learned. Right now a little bit more in detail. Knee chest position, we already know how it works. King's venous return, reduces venous return from the lower limbs, improving the pulmonary perfusion. So let less of blood coming into the heart and increase systemic vascular resistance. So overall the blood that is there moves into the pulmonary circuit. Oxygen administration, 100% humidified oxygen via face mask, improved arterial oxygenation, reduces and reduces pulmonary vasoconstriction. So, we already know hypoxia is a feature, not a feature, it causes pulmonary vasoconstriction. So, you give more oxygen, it improves. Or morphine sulfate, we are learning the dose now, 0.2 milligram per kg subcutaneous or IV. It reduces the hyperapnea, induced increased systemic venous return. So, venous return reduces. So, whenever you breathe in deeply, there is a lot of negative intrathoracic pressure. So, this negative intrathoracic pressure drives the increased venous return, it causes the increased venous return. So, what you do is you reduce this apnea and the venous return reduces, and then you have relieving of this, what is it, there is less of pressure into the pressure that is being filled into the right side and this thing compared to the left. So, it is always about the comparison with the left. So, left versus right. So, the left should always have higher of pressure compared to the left should have more of pressure than the right, but that is why you always try to reduce the pressure on the right side by doing lot of things, and this is one of them, reducing the respiratory drive, ultimately leading to less of negative intrathoracic pressure. Propranolol 0.5 to 1 milligram per kg per dose, IV 1 milligram, that is 0.2 milligram, IV orally over 6 hours. Every beta blocker that reduces infundibular spasm, we have already seen, slows heart rate, improving diastolic filling time and pulmonary blood flow. Sodium bicarbonate, correction for acidosis, and which acidosis worsens the hypoxia. Then there is vasoconstrictors. The vasoconstrictors, we already know SVR should be increased. We use phenylephrine and metarminol. This is the first time we have phenylephrine, I know it, metarminol is different. Coming to IV fluids, normal saline or ringer lactate expands intravascular volume, improving right ventricular output. IV fluids, normal saline ringer lactate expands intravascular volume, improving right ventricular output. Yes. Coming to intubation and mechanical ventilation, required if the spell is severe and refractory to initial treatment. So, finally, we do these last two things. Next, coming to definitive treatment. So, oral propranolol 0.5 to 1 milligram per kg every 6 hours, long term to prevent recurrent spells, and this is mainly for the spasm, because spasm can happen out of nowhere. Iron therapy treats anemia and which can exacerbate cyanotic spells. So, already we know there is hypoxia. So, why would you not treat anemia? You should be treating anemia to improve whatever blood is, whatever there is, treat it. And then these are the points, we already know what these are. Total surgical repair, and then there are these extras. So, we are done with the tetralogy of Fallot. Now, coming to some topics that overlap very nicely with medicine, that is rheumatic fever, CCF and infective endocarditis. Hopefully, we should be able to finish a good chunk by the end of this 50-minute session. Let me drink some water. Yeah, coming to ARF, which is not acute renal failure, it is acute rheumatic fever. It is a delayed non-suppurative sequelae of group A streptococcus, gas pharyngitis, GAS, gas pharyngitis, group A streptococcus. Primarily affects the joint, skin, subcutaneous tissue, brain and heart, and because of that there is the Jones criteria, which says J for joints, O for looks like, let us see, nice animation, Jones, there should be a nice one, yeah, this is the one. J for joints, you can see the joint, This is the heart, carditis. First one is joints, second one is carditis. There is arthritis also, that comes in the first one, polyarthritis. N for nodules, you can see the nodules. E for you can see the erythema margin, you can see the skin lesions. And as for pseudonym scoria, it is motor disorder. Yes, motor manifestation. This is a very good image. Next, coming to this, we just went through the definition. Among these, cardiac involvement can lead to long term complications such as, so you can have carditis, and the long term complication is rheumatic heart disease. So, rheumatic fever caused by gas pharyngitis, following gas pharyngitis, and long term complication is rheumatic heart disease, making it the most significant consequence. It is a consequence, RHD is a consequence. Epidemiology, should we even go about it? Let us see, affects the children between 5 to 15 years. Yes, this is important. And then common in, where is it seen? Just like every other infectious disease, overcrowded, socio-economically disadvantaged neighborhoods, populations. Now, coming to pathogenesis, disease mechanism is due to molecular mimicry between M proteins of gas and myocardial proteins, particularly myosin. So, myosin has that M protein and also this gas. So, antibodies against the gas cross react with the heart tissue, which is the myosin, leading to inflammation, valvular damage, ash of bodies. Wherever this M protein is, there is inflammation, and leading in, and that is in the heart. So, that is inflammation of the heart muscle of the heart entirely. So, that is carditis. So, what kind of carditis it is? There is pericarditis, which is pericardial, this thing, the sac. Then there is myocarditis, myo meaning the muscle, and the endocarditis, the innermost layer. So, almost all the pancarditis, it is it could be pancarditis. So, there is chest pain and pericardial rub in case of pericarditis. Myocarditis, there is, these are the features: soft S1, S3 gallop, cardiomegaly. So, this is a little complicated even at my level. So, I would prefer memorizing this: soft S1, S3 gallop and cardiomegaly. Cardiomegaly makes sense though, because this is inflammation of the muscle, and this inflammation meaning increase in size. S3 gallop also is it the stiff ventricle thing? Stiff ventricle, S3 in heart, I think it is S3, S4, sometimes I get confused. So, I doubt. Right after S2 occurs rapid filling of the ventricle caused by sudden deceleration of blood flow into a dilated non-compliant ventricle. Yes, it is dilated non-compliant ventricle. So, dilated non-compliant ventricle, fine, makes sense in myocarditis. And S1, it is atrioventricular walls. Yeah. So, walls are also affected. So, endocarditis, what are the walls? Mitral highest, then aortic, then tricuspid, MAT involvement, the gas and the MAT leading to. So, we are talking about Jones criteria, and in the Jones criteria we have the major criteria and the minor criteria, and we are in the major criteria. So we finished pathogenesis. Now, we were talking about the clinical features. So, talking about the clinical feature, we directly jumped on to the criterias, because the criterias include the clinical features, and the major criteria, carditis is the major one, and it is, we have already discussed these three things. And then talking about how it is detected, is echocardiography. Next, coming to polyarthritis. So, within the Jones, it is the J, polyarthritis, migratory polyarthritis affecting large joints. Chorea, pseudonym chorea, involuntary non-repetitive movements affecting fingers, hands and face. Subcutaneous nodules, firm and painless, mobile, associated with carditis. Erythema marginatum, non-pruritic annular rash seen over the trunk and inner arms. Then there is the minor criteria, where there is fever very high and polyarthralgia. What is the number? Greater than 38.5 degrees Celsius. So, minor criteria, that is what we are talking about, and first one we are done with, which is the clinical criteria, wherein there is fever and polyarthralgia. Arthritis, this is arthritis, inflammation, this is arthralgia, this is the pain, and there is laboratory, which is elevated ESR, CRP and prolonged PR, and there is supporting evidence. What is the supporting evidence? Positive throat culture or streptococcal antigen test. And what is the main antibody titer that we have? ASO titers, anti-streptolysin. I think that's the anti-streptolysin. O greater than 333 units in children, and anti-DNase B 480 units in school age children. Oh, these are numbers: 333 in children, that is the ASO, and then there is anti-DNase B, that is 480. 333 ASO, 8 anti-DNase is 480, greater than that. And then we already seen this is one of the minor criterias. So, ESR greater than 60 and CRP greater than 6. So, 6 and 6, 60 and 6 makes sense, and echocardiography is one of the major criterias. So, it detects the carditis and detects the valvular dysfunction, which is endocarditis and mitral regurgitation. So, what is this thing of valves? MAT, mitral aortic tricuspid. Next, coming to ECG, there is prolonged PR interval, which was one of the minor criterias, prolonged PR interval. Next, coming to the ECG, cardiomegaly is seen. So, cardiomegaly was here because of myocarditis. Next, coming to throat culture, which was one of the supporting evidence. Throat culture, streptococcal antigen test or the throat culture. So, where is it? Throat culture positive only in very few conditions. Diagnosis, there is revised zone criteria. There are two major criteria. We have seen what the major criteria are: JONES, all of them, and one major or one major, two minor, plus. So, one major and two minor. So, there is or here, one major, two minor, along with it one supporting evidence for the infection. Next, coming to the differential diagnosis. So, juvenile idiopathic arthritis, this is, I think it has been mentioned somewhere, probably here itself down somewhere. Rheumatic section, is there rheumatic section here? Yeah, here it is. I think it is mentioned here, hopefully. Persistent joint symptoms and arthritis, and systemic lupus, erythematosus, reactive arthritis. Next, coming to the treatment. So, treatment, what do? We know the cause, it is gas infection, group A streptococcus. So, benzathine penicillin, it is given benzathine penicillin G is given IM 1.2 million units greater than 27 kilograms, and if it is less than 27, you half, reduce it by 2, no, divide by 2, then it becomes 0.6 million international units, which is 600 K. And oral penicillin V is 250 milligram QID for 10 days. First one is IM, next one is oral, 250 milligram QID for 10 days. Next is erythromycin. If there is an allergy, 20 milligrams, so 20 milligrams per kg per day. So, erythromycin. First one benzathine penicillin G, which is IM, so it is in millions, and you have to divide it 2 based on the weight bands. Then there is penicillin V, which is oral, 250 milligram QID for 10 days. Then erythromycin. Erythromycin, why? Because whenever there is penicillin allergy, not allergy, 20 milligram per kg per day. So, then we have treated the infection. So, what is there? What do we have? What else do we have? So, the sequelae, what sequelae? There is arthritis, there is carditis. What do you do with that? For those, we have aspirin 100 milligrams per kg per day for 2 to 3 weeks, and then taper it to 60 to 70%. 100 taper by 60 to 70, taper to 60 to 70% of it. If aspirin intolerant, naproxen 10 to 20 milligrams per kg per day. Then if no response, corticosteroids. So, corticosteroids at the end. First aspirin, naproxen, then that is corticosteroids. Moderate to severe carditis. So, this was for mild carditis. So, we saw here corticosteroid last resort. So, where do we use corticosteroids? If there is mild to severe carditis or CCF, 2 milligram per kg per day, maximum 20 milligram per day, taper over 4 weeks. So, this was the number 2 milligram per kg per day. IV methylprednisolone 30 milligram per kg per day for 3 days in severe cases. Management of pseudohypoalbuminemia, which is involuntary motor movement of the hands and all that. Haloperidol, phenobarbital, chlorpromazine, all these could be used. Supportive care, analgesics for pain relief, rest individuals based on symptoms, hospitalization required for severe arthritis, carditis and chorea. Prevention. So, we are done with most of the treatment. Now, coming to the prevention, 10 day course of penicillin for streptococcal pharyngitis. Secondary prevention, there is, if there was no carditis, 5 years or 21 or until 21 years of age, mild to moderate carditis, 10 years or until 25 years. So, double it, and here 21 to 25, severe carditis, lifelong prophylaxis. So, that is how we come to the end of rheumatic fever. Next, coming to congestive cardiac failure. Congestive cardiac failure is a clinical syndrome characterized by the inability of the heart to pump sufficient blood to meet the metabolic demands of the body. So, heart is failing heart, congestive cardiac failure, can't pump out enough blood to meet the demands. It results in systemic or pulmonary venous congestion or both. In children, the causes vary, it will be congenital or acquired, and based on the age group we have divided them. At birth, the causes could be hydrops fetalis. So, what is that? We have seen it in erythroblastosis fetalis. Then there is hypoplastic left heart syndrome, volume overload. So, causes could be quite vague, like it is hard to actually pin it down to this particular age, but still we can try. So, CCF. Next, coming to first week, what do we have? Transposition of great vessels, patent ductus arteriosus, TAPVC. Then there are stenosis. So, 4 causes, 4 causes for first week, 3 causes at birth, then 2 causes at 1 to 4 weeks, almost a month. First week, first month, 1.5 month, and then 4 months. So, coarctation of aorta and large VHD PDA in preterms, and then there is endocardial cushion defects and large VHD in case of almost 1.5 month, 1.5 month. So, maybe better would be just to look at it for a while, just look at it and just imagine it, and then try to remember. I have looked at it, then I will try to remember it, but not right now. Now, I need to finish this. Then there is 6 weeks. Maybe it is a good idea to try getting a mnemonic for this. Let us see if it goes down. It does not. So, let us see just for the congenital. Acquired, I think we can do something. Congenital is like quite vague. Let us see if there is a good way to remember. If it is good enough, I will be really happy. Oh, at birth there is HTPCEV, heart stake proper coordination every visit, heart stake proper coordination every visit periodically. Okay, logical explanation. At birth, defect that severely affect oxygenation. High drops, okay, makes sense. HLHS, hypoplastic left heart. Okay, left heart, because left heart is pushing out the blood through the aorta into the systemic. That is a problem. Okay, severe shunts. Okay, fine, severe shunts. Okay, those things. Then there is severe shunts. Yeah, volume overload. Fistula is the only severe shunt that and regurgitations. Volume overload states, fine. First week, duct dependent lesions. First week it is duct dependent. So okay, these two are duct dependent. Okay, this one and some stenosis. TAPV transposition, this one, and stenosis. Oh, stenosis also. Yeah, stenosis. Stenosis could be like once you have a block somewhere, you need a shunt or duct so that it flows through more easily as the duct closes. First to 4 weeks, pressure dependent lesion. So coarctation of aorta. Okay, so coarctation is that thing like when the descending aorta goes down. So pressure difference in upper limbs and lower limbs. Large VSD. So large VSD and PDA in preterms. PDA in preterms. Well, this is pressure dependent. PDA is repeated again. And yeah, VSD because you need, it shouldn't go from right to left, it should be left to right. Then 4 to 6, this cushion defects becomes and larger shunts become symptomatic as pulmonary vascular resistance drops. Cushion defects and larger shunts become symptomatic as pulmonary this one. Let's see what this thing is. 4 to 6, endocardial cushion and large VSD. Okay. Something we'll remember out of the because of the explanation. 6 weeks to 4 months, VSD PDA remain prominent as symptoms worsen with left to right shunting. Let's see what this thing is. Hearts take proper coordination visit very seriously, very periodically. Hearts take periodic proper coordination every visit periodical. P is not there, fine. Hypoplastic HHH, fine. First one done. Transposition T, tiny PDA, tight walls. Stenos. Yeah, this is good. PDA, P for P at which first to 4 weeks. Yeah. Persistent preterms, pressure issues. Okay, fine, good. Next one is cushion defects. Yeah, see, good. Congenital large VSD. Yeah, let me check it. Maybe we are reading some. Yeah, it's perfect. It's working. Next, coming to V, very painted ductus arteriosus. Okay, this is very nice. Let me copy this and plus. Yes, this is very nice. The first one is the good one. So let me mark it. Yes. Coming back next to the acquired causes, let's do the same for this too because it is very helpful. Now for this, very active kids require careful handling from infancy to older. Very active kids, V for viral myocarditis, very fast heart rate. Okay, SVT, very low blood. Let's see if it is right. Yes, it is right. Very active kids require careful handling. A for aneurysms, Kawasaki disease. Yes, 1 to 4 years. K for carditis, kicked up metabolism. Okay, cardiomyopathy and chemotherapy. Okay, this is good. K. Yeah, greater than 5 years. 1 to 4 years, greater than 5 years. R for rare genetic disease, require rare genetic disorder, muscular dystrophy. Okay, respiratory problems, that is also R. Okay, the respiratory problems, let's see what it is. Yeah, where is it? Yeah, hypoxia. Then H, what do you do? Hypertension. Okay, they just included it here. C for critical metabolic issues, hypoglycemia, acidosis, and H for heart blocks. Okay, all of it is under others. Let's see. Let's save it somewhere. Logical flow, most acute causes. Okay. Vascular inflammation. Okay. Chronic conditions. Okay. Genetic metabolism. Okay. Anyways, that's not important. We need to just save it here because mnemonic has made our life much more easier. Okay, pathogenesis. So, pathophysiology of CCF explained by two laws. Frank-Starling's, which is from physiology, increased ventricular end diastolic volume preload enhances cardiac output, and there is Laplace law, 2T pressure times radius divided by 2 times the wall thickness. So, wall tension inversely proportional to the wall thickness, directly proportional to the pressure and radius. Yeah. So, these are the laws, Frank-Starling's law and Laplace law. If we start discussing this, we will have to start discussing entire physiology. And compensatory neurohormonal mechanisms, sympathetic activation and RAS. So, this is the immediate one. So, increased epinephrine norepinephrine leads to increased heart rate, contractile and cardiac output. Adverse effects include increased afterload, hypermetabolism and arrhythmogenicity, myocardial toxicity. Okay, yeah, everything, all of it makes sense. Renin, RAS, decreased renal blood flow, increased renin, angiotensin 2 increases and leading to myocardial hypertrophy, leading to increased fluid levels in the body, which can lead to myocardial hypertrophy. That would be a really nice way, or directly maybe it does. Let's see. Directly, that is the question mark. Does angiotensin 2 directly cause this? Not directly. Angiotensin 1, angiotensinogen, yeah, angiotensin 2 promotes fibrosis. Yeah, it's not via the fluid absorption mechanism, but it does it directly. So that is something new that we learnt about. Okay, it has turned into a new one, which is very interesting. Next, coming to the clinical features. What time is remaining? 2 minutes. It's fine. We'll try to, what's this? Yeah. Clinical features. So, history and clinical examination. History of poor feeding, sweating during feeding in infants. So, what topic are we talking about? Congestive cardiac failure. So, poor feeding, dyspnea on exertion, easy fatigability, puffy eyes, swollen feet. So, right heart failure features, and these are general features, and sweating because of increased sympathetic. Examination findings, compensatory mechanisms, we have seen this already. Pulmonary congestion, there is tachypnea, dyspnea, orthopnea, PND and lung crepitation, because blood is backing up in the pulmonary circuit because the left heart is failing. Systemic congestion because right heart is failing. Distended hepatomegaly, puffy eyelids, distended neck veins, jugular venous pressure increases. And then there is chest X-ray, cardiomegaly, ECG identifies underlying cause. ECG identify underlying cause. Echocardiogram identifies left ventricular dysfunction. What are the investigations? Chest X-ray shows cardiomegaly and pulmonary edema. So, this one is okay, fine, makes sense. And to detect arrhythmias, secondary to the compensatory mechanisms, we need ECG, echocardiography to evaluate ventricular function and to identify structural defects. Blood pressure, we do the BNP levels, electrolyte imbalances and thyroid function. So, BNP, brain natriuretic peptide, which helps in reducing the body fluid levels, because it depends on the stretchability, like how stretching of the atria happens. Maybe it's from the, is it from the brain? ANP is from the heart. BNP, brain natriuretic peptide, maybe. Yeah, electrolyte imbalances, then there is thyroid function. pulse oximetry and arterial blood gas analysis. This also could be done. Treatment, general measures, infant seat, sits with head elevation, oxygen supplementation. We'll just finish how many? Yeah, we will finish a part of it. Let's see, we'll finish these because the drugs are a little bit more, right? And even if I go continuously, it might cause some kind of issues. So infant head elevation, oxygen supplementation, adequate calories 160 kilocalories per kg per day, salt restriction, and which is less than 0.5. Why? Because you don't want a lot of fluid overload. There is bed rest. Infant seat, oxygen supplementation, adequate calories, salt restriction, and bed rest. So with this we are done with partly the CCF, and then rest of the CCF is remaining. Then we also need to do infective endocarditis, after which you will be done with the CVS section. So for now I think better to take a break and come back after the break. Let's continue. Yeah, so what is the treatment? So we are done with the general measures. Let's go with the specific measures. So first, diuretic. So you want to reduce the fluid overload. So that is number one, to reduce the preload and the congestion. So in that particular condition, what do you do? There are some drugs like furosemide, thiazide, spironolactone, and the adverse effects of the this one furosemide is hypokalemia, hypochloremic alkalosis, sorry. And this is in brief, meaning as a 5 marker what you need to write an answer for the CCF. It's not in detail. And digoxin, it increases the myocardial contractility, parasympathomimetic effects, and diuresis. So the dosage for premature it's different, for term it's different, and for 2 years it is different, but last 2 it is for the premature it's 20 microgram per kg, the digitizing dose for this to happen, and maintenance 5. For term it is increased by 10, 30 microgram, and for 2 years increased by same thing, same number, but maintenance increases to 8, and here it increases to 10. So 5, 8, 10, here is 20 and 30 repeats itself. Digitization protocol, half of the total dose start and 1/4 of the dose after 6 hours, 1/4 of the dose after 12 hours, ECG monitoring to prevent toxicity, PR interval prolongation, ST depression. Next, coming to the afterload. So digitalization is this one, the process of the entire effect to start taking place. Afterload reducing agents, there are arterial dilatase, which is hydrolysine, venodilatase, glycerin trinitrate and isosorbide dinitrate, and mixed ACE inhibitors and prazosin, these 3. And then other drugs, inotropic drugs, amrinone for rapid action, beta blockers, there is carvedilol, metoprolol for muscular dystrophy and post myocarditis cardiomyopathy, and then there is carnitine. So these are the other section, drugs in the other section. So overall, what did we learn? There are diuretics, so name quite a few of them and write some adverse effects. And for digoxin, write the digitalizing dose and the loading dose and the maintaining dose and what the protocol is, and afterload reducing agents, and for venous, for arteriolar and the mixed ones, which includes both. Then there are inotropic agents, which is amrinone, and then there are beta blockers and carnitine. Surgical management, cardiac transplant for end stage heart disease, heart failure secondary to cardiomyopathy, hypoplastic left heart syndrome, which we have seen once already, but I think better to take a look exactly what it is a rare congenital heart disease, left heart severely underdeveloped and incapable supporting of the systemic circulation. Yeah, we can know what it does, what this thing is just based on the name. Failure of Fontan circulation. What's Fontan circulation? A surgical procedure that redirects blood from systemic veins into the lungs without a functioning pump. So earlier, that was the one, the subclavian thing, subclavian to pulmonary artery. Yeah, that is a Fontan circulation. So cardiac transplant in that condition, palliative congenital heart disease. Then recent drugs. So there are calcium sensitizing agents, levosimendan and pimobendan, nesiritide, recombinant human being natriuretic peptide. So this is for reducing the fluid overload, and there are vasopressin receptor antagonists So, vasopressors, these reabsorb the fluids, but antagonists, they do the opposite. So, here we have conivaptan, relcovaptan and tolvaptan. Conivaptan, relcovaptan, tolvaptan, dual V1A and V2, selective V1 and selective V2. Then there are metabolic modulators like perhexylene, V1A, V2, V1, V2. Conv is for both, relcovaptan is for V1, tolvaptan is for V2. And that is how we are done with the discussion on CCF. Next, coming to the last topic, which is infective endocarditis. We will be going through the clinical features and the management. So, clinical features, it is a severe infection affecting endocardium, particularly the endocarditis, right. So, endocardium, particularly heart valves. So, the following clinical features help in the diagnosis. So, what history do you find? Predisposing factors are congenital heart disease and IV drug abuse, IV drug use. Recent dental procedures, prolonged fever, weight loss, myalgia, arthralgia, easy fatigability are some of the findings, some of the history findings. Physical examination, what do we see? New or changing murmur in cardiac section, signs of CCF in advanced conditions. So, ultimately it is the CCF, even in rheumatic side, even over here it is the CCF at the end. Systemic manifestation, fever and splenomegaly. Then dermatologic findings due to embolization. Embolization meaning the endocarditis is affected, and endocarditis, there could be a formation of thrombus and emboli, which eventually lodge into the systemic circulation. So, or systemic circulation, yes. So, mucous membrane and the skin, petechiae could be seen, splinter hemorrhages. So, do you want to see infective endocarditis? Infective endocarditis skin findings. So, you can see here, oh yeah, there was nice image, not this one. Yeah, splinter hemorrhages, Janeway lesions, Osler's nodes. So, Osler's are painful. How do you remember that? Ouch, ouch, Osler. Ouch meaning it is painful. Conjunctival hemorrhages. Yes. Next, coming to Osler's are painful. Rod spots are retinal hemorrhages with pale centers. Neurological, so systemic embolic phenomenon, one of them is the brain, and there could be stroke, focal seizures and brain abscess. And dental findings, caries tooth, because this one was a predisposing factor, caries or tooth infections. So, what are the laboratory findings? Blood culture positive in 90% of the cases, 3 separate samples in 24 hours, 3 separate in 24 hours. Previous antibody use may reduce positivity, antibiotic use may reduce positivity to 40%. So, make sure that you know. Complete blood count, there is anemia, thrombocytopenia and ASR being raised. And then echocardiography, there could be on TTE initial imaging for cardiac involvement. So, how heart is involved, and transesophageal echo, more sensitive, detects small vegetation and wall damage. So, 2 things, echo, transthoracic echo, transesophageal echo. Then under the treatment section, we have management of IE involves prompt initiation and antimicrobial therapy, surgical intervention in selective cases. So, medical treatment. So, there is empirical antibiotic therapy, there is native wall endocarditis, and there is prosthetic wall and a lot more. So, native wall endocarditis caused by these organisms, Viridians bovis. There is penicillin and ceftriaxone for that, for 1 month. Then in the staph endocarditis, there is MRSA, MSSA and MRSA. MSSA, penicillin resistant beta lactam, nafcillin. So, nafcillin is a very important antibiotic for staph. So, in this particular condition, if it is methicillin sensitive, we give nafcillin plus or minus along with gentamicin for 5 days. If it is methicillin resistance, as we all know, vancomycin is the way to go. Then gentamicin for overall for 6 weeks. This one for 5 days, this one for 6 weeks. With this we know MRSA how bad it is. Then there is enterococcal. Enterococcal carditis, endocarditis, there is ampicillin, gentamicin for 6 weeks. HASIC, there is ceftriaxone, gentamicin. HASIC is, what is the full form? I forgot what the full form was. Haemophilus aggregator cardiobacterium, Eikenella kingella. For those, there is ceftriaxone similar to this ceftriaxone over here to native wall, and then there is you could also use ampicillin and gentamicin being repeated everywhere except the first one. Fungal, it is amphotericin B, and prosthetic wall 6 weeks of targeted therapy. And surgical treatment, progressive congestive cardiac failure. If there is congestive cardiac failure or prosthetic wall malfunction or positive blood culture despite 2 weeks of antibiotics, so keep giving antibiotics, it does not work. What do? You go for surgical treatment or bacteriological relapse. In those particular conditions, we look at surgical treatment. Next, prophylaxis. Indications for prophylaxis. Cardiac conditions. So, prosthetic wall. So, there is this prosthetic wall endocarditis, which means this one is the predisposing factor. So, make sure that there is prophylaxis, previous history of infective endocarditis, congenital heart diseases like unrepaired cyanotic lesions, residual defects after repair. Procedures requiring prophylaxis. What are the procedures? Dental procedures, respiratory procedures and GI genitourinary procedures. Manipulation of gingival tissues or perforation of oral mucosa. Specifically, when we talk about dental procedures, gingival tissue manipulation or perforation of oral mucosa, respiratory tonsillectomy, bronchoscopy with biopsy, and GI procedures in infected tissues. Recommended antibiotic regimens for prophylaxis, there is for this one, for mouth related and respiratory related, there is amoxicillin or ampicillin, and allergic to this cephalexin. Then there is GI genitourinary, ampicillin, gentamicin. Gentamicin is back. GG, G for genitourinary, G for gastrointestinal, G for gentamicin as prophylaxis within 30 minutes before the procedure. Because this is prophylaxis repeated after 6 hours. Treatment, this is before this section. Treatment, drugs should be started 1 hour before or 30 minutes, 1 hour before 30 minutes before the procedure. Yes, so we are done with prophylaxis. So, before doing the procedure, take the drugs, and thus we have come to the end of this discussion. But one last final, cyanotic versus acyanotic heart diseases. We need to know the classification, it is important. So, classification, there is cyanotic, there is tetralogy of Fallot, we know it, tricuspid atresia, other univentricular transposition of great artery, total anomalous pulmonary venous return. But acyanotic, there are lot more, VHD, AHD, atrioventricular septal defect, patent ductus arteriosus, aortic stenosis, pulmonary stenosis, coarctation. These are acyanotic. So, many are acyanotic, but the cyanotic are very less, which is TET, tricuspid atresia, and transposition of great vessels, and total anomalous pulmonary venous return. So, that is how we have come to the end of the discussion on the most repeated ones in CVS, but make sure that you go through the other ones too, because you can't really tell if some bouncer pops up, and then you can't blame this particular website, because this I already told you it has been compilation of the most repeated questions. Now coming to kidney and urinary tract. So, we are in the 16th chapter, and this is the second last big chapter. So, another big chapter is CNS. Big in the sense compared to the rest, it is fine, I guess. The pyogenic biggest ones are these, and then CP, it is the practical case too. So, let us see how we do it, how we can go about doing this, then it is a smooth flow. So, PSGN, post streptococcal glomerulonephritis. So, what is it? It is an immune mediated disease characterized by, is the mic on? Yes, it is. Characterized by inflammation and proliferation of glomerular tissue following streptococcal infection. So, there is streptococcal infection, and because of that there is glomerular tissue proliferation. It is a type of post infectious, after infection there is glomerulonephritis. So, post streptococcal, post this, it is commonly seen in children aged 5 to 12 years. Alright. Next, coming to which one were for, what was the age for gas? 5 to 15. Etiology, PSGN is caused by immune response following group A streptococcus. So, again group A streptococcus. Rheumatic fever, yes, I was talking about rheumatic fever. So, rheumatic heart disease, and this is rheumatic kidney disease. No, it is post streptococcal glomerulonephritis. It is following gas. So, what are the bacteria? What are the other infectious causes? There are bacterial causes, viral causes, parasitic causes, and miscellaneous causes. So, we are done with strep. Then there is staph, then pneumococcus. Streptococcus is acute hemolytic group A, then there are others too, then Neisseria, meningitidis, Salmonella, Leptospira. Then there are virals like BC, hepatitis B, C, cytomegalo, EBV, Coxsackie, rubella, mumps. Measles is not there. So, mumps and rubella and varicella, but it stands MR, and says MR. And varicella. Parasitic, there is Plasmodium, Toxoplasma, Schistosoma. Then miscellaneous includes miscellaneous causes, infective endocarditis, catheter related infections, which is fine. Next, coming to pathogenesis, molecular mimicry, again just like M antigens in rheumatic heart disease, rheumatic fever. Antibodies against streptococcal antigens cross react with glomerular antigens, forming immune complexes. So, these immune complexes, antigen antibody, combine to form immune complexes, are deposited in the glomerular basement membrane and mesangium. Activation of the complement system leads to inflammation. So, complement system is required for clearance of these immune complexes, and this process is entirely this process we have. After this we have inflammation. So, complementary activation, depression of C3 of serum C3. So, C3 is getting used up to remove these immune complexes is a hallmark feature, and release of inflammatory mediators, leukocytes, macrophages, cytokine contribute further to the damage. And histopath, what do we see? Histopath of kidney, light microscopy, electron microscopy, and immunofluorescence. Enlarged ischemic glomeruli, mesangial proliferation, neutrophilic infiltration. So, we will see PSG and HPE. So, let us see, somewhere they might have written something nice. Oh, this is different. It's fine, we will look at this itself. Let us find the neutrophils. Can you find the neutrophils? We can see the enlarged glomeruli. Okay, that one is fine. Neutrophils, can we see the neutrophils? We can't. Yeah, yes, we can. Some small cells, blue cells. That is one. What else was there? Mesangial proliferation, interstitial inflammation. Interstitial inflammation, can't really make out. I am not a pathologist. Mesangial proliferation. Mesangium is the connective tissue of this particular region. Okay, something might have. There is increase. That is what I know. Increase of something. Explain. It's not really given clearly anywhere. Let's see this one, showing increased inflammatory. Okay, increase in lots of blue, but there's less of blue dots. Yeah, mainly it's the neutrophilic infiltration. Then electron microscopy, electron dense deposits in glomerular basement membrane, which are the immune complexes, is what I think. Then there is electron dense. Then let us see electron microscopy for PSGN. Electron micro. Yeah, they have shown some arrow marks. Yes. Okay, these are some huge things. Electron dense. Glomerular basement membrane. I remember reading this, but the way it's very hard for me to remember the kidneys histopath changes, but it's fine. We just need to remember the key words: granular, lumpy, bumpy IgG deposits in capillary walls. So this is for immunofluorescence. Coming to predisposing factors. What time is it? We have half an hour more. Yes, good. Predisposing factors: age, school age greater than 3 years, so 5 to 12 years was this thing. Male predominance. There is this one. What is it? Recent streptococcal infection. There is pharyngitis and protein related mimicry, right? And there could be impetigo, which is skin infection, strep skin infection, and genetic susceptibility with certain HLA types. Clinical features: latent period 1 to 4 weeks after streptococcal infection, 1 to 4 weeks after the infection. And then classical triad includes hematuria, kidneys affected, gross hematuria, and this is the keyword: Coca-Cola colored Coca-Cola, no, cola, not Coca-Cola. Coke is the other. This cola colored urine. Edema starts with facial puffiness, progresses to pedal edema, ascites, and anasarca. Cis acute nephritic syndrome. I think it is. Is it another question? No, it is not. It's in medicine. Acute nephritic syndrome is a question in medicine. Baby. Yeah. Anasarca, hypertension. Yeah, hypertension due to fluid overload and renin activation. So it is all haywire because kidney has been affected and there is a lot of fluid retention because renin is overactive. Other symptoms: oliguria, malaise, headache, abdominal pain, fever. Severe cases may present with encephalopathy, seizures, heart failure. Encephalopathy, brain problems; seizures, brain problems; heart problems, heart failure. Complications: hypertension, hypertensive and emergency in 10% of the condition; renal failure, acute renal failure in severe cases; electrolyte imbalance, which includes hyponatremia, hyperkalemia, metabolic acidosis. So, and then nephrotic range proteinuria. So, a lot of proteins being lost in the urine. electrolytes being affected, heart failure already seen, and then fluid overload and all that, and then there could be convulsions, hypertensive encephalopathy. One thing we need to know, better to know, why there is hypertension in HTN and PSGN. This is somewhat, this would be very nice. Fluid overload, renal system. Here why it happens, glomerular inflammation causes reducing GFR reduces, and because of that sodium and water retention happens, okay, and RAS activation leading to vasoconstriction, sodium retention, increased vascular permeability and endothelial dysfunction, sympathetic nervous system activation, and further causing vasoconstriction and blood pressure increasing. So, this is the one, let me check, yes, this is the one, need to do the plus and add another. Yeah, now coming to, we know why the hypertension happens, renal failure because kidney is bad, heart failure because of fluid overload, pulmonary edema because of fluid overload, convulsions because of hypertension. Next, coming to investigations, urine analysis, RBCs are found, red blood cell counts, proteinuria, then blood cells, the blood test, sorry, not blood cells, blood test, low serum C3 returns to normal in 6 to 8 weeks, elevated ESR, ASO titers, anti-DNSB, these we have seen in rheumatic fever also, streptozyme test for recent streptococcal infection, throat swab to detect group A streptococcus, group A beta hemolytic streptococci, imaging, cardiomegaly, pulmonary edema in severe cases, renal biopsy, so severe prolonged renal failure, persistent low C3, nephrotic range proteinuria. So, these are the findings, renal failure which is a complication, persistent low C3, nephrotic range proteinuria. So, these are not the findings, these are indications, sorry, I was thinking, yeah, this should be something pathology related, why is it something totally different. Yeah, so these are the indications. So, kidney going really bad, low complement levels because they are trying to fix the immune complex that are deposited. And then coming to treatment, treatment is supportive because it is self limiting, and general measures include, there are general measures, diet, fluid management and medications. Hospitalization in severe conditions, severe cases, oliguria, severe hypertension and encephalopathy, bed rest is not required in mild conditions. Diet and fluid management, sodium and fluid restriction because it is a hypertensive state, in hypertensive state and oliguric patient because you are not urinating enough because kidney is suffering, and protein restriction until blood urea. Yeah, so burn levels also need to be measured. Where is it? Yeah, we need to measure that too. It was not mentioned there too, so not included, but it is fine. It is in detail. We look at medicine. Anyways, sodium and fluid, daily weight monitoring to assess fluid retention because there is anasarca, edema and all that. Coming to medications, we want diuretics because we want to reduce the fluids that are present in the various spaces. So, not indicated in mild cases, furosemide 2 to 4 milligram per kg for pulmonary edema in pulmonary space. Hypertension management, fluid and salt restriction, antihypertensive, beta blockers, ACE inhibitors and CCBs, nifedipine. And hypertensive emergency, we have IV nitroprusside or labetalol, antibiotics not required, but if there is active streptococcal infection which is This is for recent, but for culture, using culture and all that, if you get to know that there is present right now, we do penicillin for 10 days to eradicate the strains. Dialysis indication, severe renal failure, prolonged oliguria, and severe electrolyte imbalance. And prognosis is spontaneous recovery 95%, more than that. CKD is rare, and proteinuria hypertension may resolve in 4 to 6 weeks. Prevention, early treatment of the infections, family screening of carriage in recent infection, good hygiene practices. And we have come to the end of discussion on PSGN. Next, coming to nephrotic syndrome. Nephrotic syndrome, we will be looking at everything, clinical features, complications, investigations, treatment. Yes. So, coming to what it is nephrotic. There is, so what are the key features? So, there were certain numbers, I think better to include those numbers here too. So, investigations, yes, these were the numbers. So, but overall, what is nephrotic range? What is nephrotic syndrome composed of? Like, I think this has been given in more detail in medicine. Always I am referring to medicine. Yeah, so, but overall, this nephrotic range proteinuria is associated with hypoalbuminemia, hyperlipidemia, and edema. And there are certain numbers that are associated with those, and it results from increased permeability of glomerular filtration barrier. Increased permeability is the key. So, this is the general overview of what it is, and then coming to the etiology, what causes it. So, there is idiopathic and secondary causes. Idiopathic, there is minimal change disease. Next, coming to focal segmental glomerulosclerosis and membranonephropathy. Idiopathic type, 3 different types, and why there are 3 different types depending upon the histopathological findings and all the electron microscopy and immunofluorescence. And other causes. So, idiopathic is done. Other causes include infections, endocarditis, hepatitis B, C, HIV, malaria, toxoplasmosis, schistosomiasis. So, some of these cause these also. So, that needs to be kept in mind. Hepatitis, not exactly sure which particular one, but these can cause one of these. Predispose, maybe that is the right word. Drugs like captopril, penicillamine, NSAIDs, and immunological allergic disorders like vasculitis, food allergen, serum sickness. Genetic finish type, nephrotic syndrome, absence of nephrin and mutation of nephrin podosin, malignancies like lymphoma, leukemia. So, we copy this because we want a good mnemonic to remember this. So, we copy this, we paste this and make it easy to remember, Yes, I dig M, I for infections, okay, D for drugs, captopril, okay, fine. I thought it would give some mnemonics for drugs, like specifically these captopril, penicillamine and NSAIDs, but it's fine. Immunological or allergic disorders, vasculitis, food allergies, okay, it's not required because I dig M. Finish type, nephrin podosin, not required actually, but it's fine since it's already here, better to put it here somewhere. I ding M. Vasculitis, food allergens, serum sickness, finish type, nephrin podosin, and lymphoma, leukemia. Next, coming to pathogenesis. Loss of podocyte integrity. Podocytes form the filtration barrier in the kidney. Damage to podocyte leads to effacement, increase the permeability, which is the main cause of all the issues. Protein loss in the urine. So now you have permeability, increase in permeability. So what is getting lost? Albumin, and this results in, so what is the quantity? Greater than 3.5 grams per day, and there is less of albumin in the serum. So there is less than 2.5 gram per deciliter. Loss of clotting factors and immunoglobulins increase the risk of infections and thrombosis. This is, yes, because protein is lost. So these are the proteins, right? These are lost. Compensatory hepatic lipoprotein synthesis, hyperlipidemia, serum cholesterol. So lipoproteins, the amount of it increases, leading to specific. Let's see. Wait a second. This one, paste it here. Why? Lipoproteins, enough protein, large amount of albumin, leading to hypovolemia. This leads to compensating by increasing protein synthesis, which is not only albumin but also lipoproteins, leads to hyperlipidemia. Why? Mechanism, yes. Yeah, ramps up the protein production, overproduction of lipoproteins. Okay, along with albumin. So there is VLDL, LDL, and cholesterol. Reduction of lipid. So you have a lot of these LDLs, DLs, lipoproteins. Yes, which, so lipoprotein lipase, which break down this thing, is down regulated. Yeah, so this is the key, and because of that there is increased serum lipids and the LDL levels, leading to hyperlipidemia, which is greater than 200 milligrams per deciliter. Edema formation due to hypoalbuminemia. There is sodium retention. Thrombogenic state due to loss of antithrombin 3 proteinase fibrinolytic factors, and this leads to deep vein thrombosis. So deep vein thrombosis, so thrombus is formed because the fibrinolytic mechanism has been disrupted. What are the constituents of fibrino meaning anticoagulant section? So anticoagulant section is missing, which is that antithrombin 3 and things like proteinase and other fibrinolytic system factors. What are the clinical features? Yeah, they have spoken about, they have given the age 2 to 6 years and male predominance. Gradual onset of edema, starts periorbital puffiness, pedal edema, the feet, progression to ascites, hydrothorax, and then anasarca, decreased urine output, that is oliguria, blood pressure is usually normal, infections, increased susceptibility due to urinary loss of immunoglobulins. What are the complications? Edema complications, severe cases may lead to pleural effusion and pericardial effusion, pleural and pericardial. Spontaneous bacterial peritonitis. So effusions are seen and already there is ascites and just a little bit of infection, and then you have SBP, spontaneous bacterial peritonitis, not secondary bacterial. There is fever, abdominal pain, peritoneal sign, and common pathogen is pneumococcus. Thromboembolic events like DVT, pulmonary embolism, and renal vein thrombosis. Severe infections, there could be meningitis, pneumonia, cellulitis due to immunosuppression. Why there is immunosuppression? Because proteins are lost in the urine. So secondarily you can have all these things. Hypovolemia, these ones also anticoagulant mechanism is impaired. So thrombosis, thromboembolic events. Investigations, urine analysis, proteinuria 3-4 plus, spot urine protein creatinine ratio greater than 2, microscopium hematuria in certain, because it is majorly a feature of nephritic syndrome. Serum biochemistry, hypoalbuminemia less than 2.5 grams per deciliter, we have already seen that, and hypercholesterolemia greater than 200 milligrams. Complement levels, C3 is normal in minimal change disease, but C3 is less in lupus nephritis. We need to know why this is the case. It keeps going up. Yeah, maybe it's a better idea. This one is better. Yeah. Why? Immune complex. So lupus nephritis, what happens? Yeah, immune complex, auto antibodies against this one. Yeah, immune complex. Yes, the immune complex mechanism, same thing. Yeah, light microscopy, normal in MCD, FSGS, focal segmental sclerosis, electron microscopy, effacement of podocytes in MCD, and immunofluorescence, mesangial IgM deposits. Mesangial IgM deposit, chest X-ray, tuberculin test before starting steroids to rule out tuberculosis. So steroids are the mainstay of treatment, first line of treatment, and that's why TB should be checked for. You need to check for TB. But general measures before we go into the proper therapies: high protein diet to compensate for protein loss, yes, salt restriction to manage edema, fluid overload, diuretics for so much of fluid and edema, furosemide 1 to 4 milligram per kg per day. Earlier we saw it was 1 to 2, now it has increased. Statin therapy for hyperlipidemia if it is persistent. Prednisolone, same dose, 2 milligram per kg per day for 6 weeks. Earlier we saw 4 weeks for other things. Followed by tapering, 1.5 milligram per kg on alternate days for 6 weeks. Remission defined as proteinuria less than 4 milligram per meter square per day for 3 consecutive morning samples. Okay, this seems fine. Relapse more than 40, so 10 times, greater than 10 times of this number is reappearance of proteinuria, and probably that number is equivalent to this one of these. Yeah, maybe it's that 40 milligram per meter square per kg per day. Frequent relapses, more than 2 relapses in 6 months or more than 3 in a year. 2 in 6 months, 3 in a year. Steroid resistance, no response with 4 weeks of daily steroids, because you are giving it for 6 weeks. So first 4 weeks, if you don't see anything, that means resistance. Steroid dependence, relapse within 14 days of stopping steroids. Yes. So in case of steroid resistance, immunosuppressions could be used. Levamisole for frequent relapses, and cyclophosphamide, mycophenolate, mofetil, and tacrolimus. So, and immunosuppressants, levamisole, cyclophosphamide, mycophenolate, mofetil. These are immunosuppressants. ACE inhibitors, enalapril, ramipril, to reduce proteinuria and hypertension. ACE inhibitors. So this is all part of second line. First line is steroids. Only if it doesn't work, you go down. IV albumin for severe hypovolemia with marked ascites, and then management of complications. The complication, infections, yes, you give antibiotics because you know why that is. Thrombosis, you know why that is. Anticoagulation therapy, because this one is missing for DVT and pulmonary embolism. Severe edema, albumin infusion. Dialysis for progressive loss, renal failure. Prognosis, MCD has excellent prognosis with remission in greater than 95% of the cases. Steroid resistant nephrotic syndrome offer prognosis to chronic CKD. Relapse rates decrease with age. So with this, we have completed the discussion on nephrotic syndrome, and we shall begin with UTIs, and let's see how big this thing is. I think this is a 5 marker, not particularly sure. A 5 marker, and the last one, I think it's supposed to be a part of adolescence. In this book it is part of adolescent medicine, but here it is in renal system, but fine. So UTIs, UTI are common in the bacterial infection in children, most common, with non-specific minimal features, making diagnosis challenging. So it's non-specific. If untreated, UTIs can lead to renal scarring, hypertension, CKD. That is an overview, but let's come to the details. Etiology. What causes it? Ascent from perineum to urethra or bladder and kidneys. The most common causative organisms include, there are bacterial causes, and then there are some risk factors. Bacterial causes. Gram negative bacteria most common. E. coli, we all know, everybody knows E. coli most common for UTI, and Proteus commonly seen in boys. There is Klebsiella, Enterobacter and Pseudomonas too. So E. coli, Proteus, Klebsiella, Enterobacter, Pseudomonas. Gram positive. Staph saprophyticus in adolescents, and then Enterococcus. Coming to the risk factors. Sex, higher in infant boys, but after 2 years girls are increased risk. Congenital anomalies of the tract, VUR, posterior urethral walls. Neurogenic bladder, spina bifida, spinal cord injury. Obstruction, stones, strictures, constipation. So you might know this from a very famous lecture, where if there is a block, behind the block there is inflammation, infection. Indwelling catheters and recurrent antibiotic use. So whenever catheter associated, and immunosuppressive conditions, wherein the body can't defend properly against these microorganisms. So risk factors are, depending upon the age, various sexes are involved differently, both are involved differently. Congenital anomalies, we have seen some examples. Neurogenic bladder, we have seen some examples. Obstruction, indwelling catheters and immunosuppressive conditions. Pathogenesis, most UTIs are ascending infection, bottom to top, where bacteria from perineum colonize the urethra and then into the bladder and then kidneys. Papillae of kidneys have anti-reflux mechanisms preventing urine entry into collecting ducts. So things don't just enter into the collecting. However, in some children, vesico-urethral reflux causes infected urine to travel back to the kidneys. So this was a risk factor, right? Yeah, leading to pyelonephrosis, renal injury and scarring. So inflammation happening in the kidneys, and then inflammation. What follows the inflammation? Fibrosis and scarring. And then recurrent infections in patients with congenital anomalies. So it is something abnormal over there. So there are recurrent infections of urinary tract, can cause chronic kidney disease damage, chronic kidney damage over time. Host immune response, like including neutrophil activation, cytokine release. So this is a physiological meaning, this thing, like what happens at the site, neutrophil, cytokine release and all that. Clinical features, symptoms based on age and severity. So age, so neonates and infants, sepsis like symptoms, fever, lethargy, poor feeding. So this was seen everywhere. Vomiting, diarrhea, jaundice, okay, failure to thrive, irritability, hypothermia, hyperthermia, any of these. So sepsis like, mainly that, sepsis like. Older children, unexplained fever, dysuria, frequency, urgency, hypogastric pain. So here down, epigastrium is up, hypo is down, foul smelling urine, enuresis, which is bedwetting. These are the features in older children: unexplained fever, dysuria, frequency, urgency, hypogastric pain, foul smelling urine, enuresis. Pyelonephritis, complicated UTI, high grade fever with chills and rigors, flank pain which is costochondral angle, costochondral is here, costovertebral angle tenderness, pylo meaning kidneys involved, right? Wait, let me finish this off. These I'll finish these classifications. Flank pain and vomiting, dehydration, systemic toxicity. Classification based on site of infection. Upper UTI there is pyelonephritis, urethritis. Lower UTI there is cystitis, urethritis. So bladder and urethra, ureter and kidney. Simple and complicated UTI. Simple UTI, it's low grade fever, dysuria, urgency, urinary retention is absent and renal involvement is absent. Complicated is high grade, systemic toxicity, vomiting present and renal involvement is also present. Urinary retention is present, renal involvement present. So you can see this almost mimics the neonates and infants are like, they get it, it is bad. Okay, so right now I am going to pause this session with break, and after this session we would be completing this entirely and also most likely even this one. Then we will go into the endocrine section 2 and we will try to finish as much as we can. But for now it is break time. The break is on. Hello. Yeah, so let's continue. Yeah. So investigations of UTI. For UTI, urine culture is gold standard. Why? Because urinary tract infection. It's infection in the first place. So there was a mosquito here. Yeah. Significant bacteriuria greater than 105 colony forming units per ml in midstream clean catch sample. Midstream 105. So these are the clean words, keywords, not clean words. Suprapubic bladder aspiration in infants, any bacterial growth is significant. Suprapubic bladder aspiration and catheterized sample greater than 50,000 colony forming units in infants less than 2 years. So in midstream urine it is greater than 105, it's clean catch sample, and in catheterized sample it is greater than 50k CFU per ml. Then in dipstick detects leukocyte esterase and nitrates. So this leukocyte esterase test, positive or negative, and nitrates positive negative. Based on that there are different organisms that could be detected. Urine analysis, presence of pyuria greater than 5 WBCs per high power fields and RBCs. Microscopic measure bacteria and pustules. Imaging studies indicated in first febrile UTI and recurrent UTI. Renal ultrasound detects structural abnormalities and hydronephrosis. Micturating cystourethrogram detects vesicourethral reflux. So micturating cystourethrogram, I have never heard of this. Micturating cystourethrogram. Okay, something like an X-ray that helps assess urinary system, how the bladder and urethra function when you urinate. Okay. DMSA scan identifies renal scarring, and what does it mean? DMSA scan. It's a dimercaptosuccinic acid scan. Nucleic acid, nuclear medicine test that evaluates health of kidneys. Okay. So if it is if this shows reduced reactive traces, so yeah, how much it has taken up. So in case it is taking less things up, that means a good chunk has been fibrosed and scarred. That section has been fibrosed and scarred. Coming to treatment, there is general management and antibiotic therapy. Then there is surgical management. Asymptomatic bacteriuria does not require treatment. Increase oral fluids and encourage frequent bladder emptying. Cranberry juice and probiotics may reduce recurrence. Asymptomatic bacteriuria, this does not require treatment. Then you have oral fluids that should be increased, then cranberry juice. Then antibiotic therapy, there is empirical therapy which includes amoxicillin, cotrimoxazole, nitrofurantoin for lower UTI, and parenteral for upper UTI, including things like ceftriaxone aminoglycoside, drugs like ceftriaxone aminoglycoside. First one was amoxicillin, cotrimoxazole, nitrofurantoin. Next one is ceftriaxone aminoglycosides. Duration of treatment, simple UTI 7 to 10 days. Pyelonephritis, double it, 7 to 14 days. Almost doubling, no, not almost, 7 to 10 days, 1.5x. So 10 to 14 days, IV antibiotics initially followed by oral therapy. Adolescents with cystitis, minimum 3 days. Surgical management indicated for recurrent UTIs for anatomical defects. So there are anatomical defects, they predispose the person to UTIs. Correction of VUR, posterior urethral walls, or obstructive uropathy. So prevention, maintain good hygiene, perineal hygiene, encourage frequent voiding and increased fluid intake, treat underlying constipation, prophylactic antibiotics, that is low dose nitrofurantoin. In case of recurrent cases, regular follow-up with imaging for high risk children, encourage circumcision in recurrent UTI among the unsubscribed males. So, with this we are done with the discussion on UTI. Now coming to nocturnal enuresis. This should be a short section, it is not, it is as big as the previous one, because this is mainly a behavioral thing. Yeah, it is mainly a behavioral thing, behavioral and a part of these. Anyways, nocturnal enuresis, bedwetting, involuntary voiding of urine at night beyond 5 years. So, beyond 5 years. So, before the age of 5 years, it should be fine. It is classified as primary if the child has never been dry for at least 3 months, or secondary if the child loses continence after a period of dryness. So, it happens, it was like that before for at least 3 months, or it started happening recently, meaning earlier he was fine, the child was fine. Why am I saying he? It could be he or she, but since it is easier for me to say it, I will say he. Anyways, coming to definition, nocturnal enuresis defined as involuntary voiding of urine at night in children aged 5 years and above, occurring at least twice a month. Involuntary voiding of urine at night in child greater than 5 years, occurring at least twice a month. Disorder of bladder control that may persist into adolescence if it is not treated. So, classification based on duration, based on timing. Based on duration, it is primary or secondary. So, primary, we have seen it already, the child has never achieved nighttime dryness for at least 3 months. So, 3 months he is bedwetting. Secondary enuresis, after a period of dryness. So, earlier he was not bedwetting, but right now he is. Based on timing, nocturnal enuresis occurs only at night, diurnal occurs while awake, mixed occurs both day and night. What are the causes? Genetic factors, 50% of the cases family history is prevalent, is positive. If both parents had enuresis, their risk is 77%. Physiological causes, delayed bladder maturation, small bladder capacity, increased bladder irritability, increased urine production at night. Delayed bladder maturation, so maturation is it has not occurred, small capacity is less, irritability is occurring, and or increased urine production. Psychological factors, stressful life, so very young child, very sad, stressful life, new sibling, school stress, trauma, anxiety, ADHD, okay. Neurological and structural causes, organic causes, spina bifida, ectopic ureter, so lumbar vertebra, sacral region are being affected. Giggle and stress incontinence, we need to know what this is. Giggle and stress incontinence. Type of daytime, it is characterized by involuntary bladder emptying during immediately after laughing. Micturition, deferral, holding urine for too long. These could be neurological causes. Hormonal factors include deficiency of ADH leading to excess of ADH is antidiuresis, meaning diuresis is prevented by ADH, otherwise too much of diuresis, which is this. Infections and medical conditions, UTIs, DM, diabetes insipidus, constipation, which can press on the bladder. And these are the etiological factors. Etiology, these are the causes. So, genetic causes we have seen, family history being main one, physiological one like the maturation and all that, psychological, child suffering from and psychological problems, neurological issues, hormonal factors, infections and medical conditions. Differential diagnosis could be associated with UTI, diabetes insipidus, like normal diabetes, normal meaning diabetes mellitus, diabetes insipidus, worm infestation and congenital anomalies. Treatment, So, we have general measures, conditioning therapies, bladder training exercises and some pharmacological therapies. Pharmacological is second line because this is mainly considered as a behavioral problem, unless there is some kind of organic cause. Reassure the parents, most of them resolve spontaneously, avoid punishment. Behavioral changes, encourage the child to avoid void before bedtime, reduce evening fluid intake. Let me consume some fluid. Use thick cotton sheets to cover mattress. Avoid caffeinated drinks because these stimulate the urine production. Maintain star charts. Do children so young, do they consume coffee? They shouldn't be. That's my personal opinion. Coming back, maintain a star chart for every night. Positive reinforcement. Then okay, these are this one behavioral changes and what not to do and counseling. Coming to conditioning therapy, this is the first line. Alarm therapy. Moisture sensitive alarms wake the child upon detecting wetness. Success rate 70% after 3 to 6 months, which is very interesting. This thing is a very interesting concept and it is good that the success rate is so high and we have it as the first line treatment, which is really nice. Bladder training exercises. Let's see. Wait a second. Let's see. We need to know how it looks like. Oh. Okay. Is the clip sensor? Then there's an alarm here. This is very interesting. It forms the first line treatment. Bladder training exercises. Bladder stretching exercises encourage gradual increase in bladder capacity, timed voiding, encourage urination every 2 to 3 hours. Then there is pharmacological therapy, which is second line after the training and exercises and all that. Desmopressin, oral drug of choice. Synthetic antidiuretic hormone to reduce nighttime urine production, used in children older than 6 years. Success rate 50%, should be used before tapering. Wait a second. Okay. Yeah. Success rate greater than 50%. 50% should be used 3 to 6 months before tapering. Oxybutylin, anticoagulant used in child with bladder overactivity. Oxybutylin is used. Imipramine, TCA, acts on the central nervous system to reduce aneurysms. Risk of overdose, so use with caution. Tolterodine, used in some resistant condition. Combination of alarm therapy and desmopressin would be really good. So desmopressin, synthetic ADH, oxybutylin for for overactivity, imipramine acts on CNS, tolterodine for resistant cases. And what is the prognosis? Okay, spontaneous resolution occurs 50% of children each year. Recurrence risk is high in children with underlying medical or psychological issues. Early intervention behavioral therapy is effective. So with this we are done with the renal section. Now coming to diabetes and the endocrine disorders. So we have congenital hypothyroidism and diabetic ketoacidosis. So let's start with, what time is it? Yeah, we have more than enough time to cover both of these conditions. So let's see. Yes, this is quite huge, but fine. Next one is also fine. Hopefully we can cover both of these by the end of this session. Overview. Diabetic ketoacidosis is life-threatening complication of type 1 diabetes mellitus caused by absolute deficiency of insulin leading to severe hyperglycemia. So insulin is it causes hypoglycemia, but absence of it causes hyperglycemia. Ketosis, metabolic acidosis, more common in children and adolescents and presents as the first manifestation. So, how do you know the child has type 1 diabetes mellitus? Most commonly it is because of this particular clinical manifestation. What are the clinical features of this particular condition? Early symptoms, and then there are signs of ketosis. Early symptoms, there is polyuria, polydipsia, polyphagia, like in adults, fatigue and weakness, weight loss despite increased appetite, because it is like a starvation kind of a state wherein the body is using ketones for energy. Signs of ketosis: vomiting, dehydration, abdominal pain, cosmal respiration, deep labored breathing, fruity odor. These are the things that connected with ketosis. Severe features: altered mental status including confusion, drowsiness, coma, severe dehydration, hypotension because you are losing a lot of water, and fever if infection is present, which can worsen the case very badly. Coming to ketoacidosis related complications, there is cerebral edema, thromboembolism, electrolyte imbalances. Cerebral edema can lead to headache, altered sensorium, bradycardia, hypertension. These things are associated with cerebral edema, and electrolyte, these are associated, not lead to, maybe could lead to, but overall these are associated with this. And electrolyte imbalance that are associated are hypokalemia, hyperkalemia, hyponatremia, and there could be thromboembolism. We need to know why this is the case. This one is like I have some idea, but better to know the reasoning so that we don't forget about it. Why? Cerebral edema, rapid osmotic shifts. Yes, this was the word. Hyperglycemia, osmotic diuresis, dehydration, IV fluid therapy, water shifts into the brain cells, causes edema, accumulation of ketone bodies, disrupts brain metabolism. Okay, bradycardia, hypertension, signs of increased intracranial pressure. Okay, but why specifically are we looking at? Okay, maybe it is related to increased intracranial pressure, which is cerebral edema. Okay, this one is related with this. Then coming to thromboembolism, hypercoagulation. Why is that? Blood viscosity. Okay. Inflammatory cytokines. Okay. Insulin deficiency decreases fibrinolysis. DVT, PA and stroke. Electrolyte imbalances, hypokalemia, insulin drives. Okay, it's related to that. Hyperkalemia, acidosis. Okay, related to acidosis. Hyperkalemia is related to acidosis. Hypokalemia is related to insulin therapy. And hyponatremia related to osmotic effect of hyperglycemia. Water shifts out of diluting. Okay. Before the therapy, the water just leaves the cells into this thing, shifts out of the cell, diluting the sodium. Okay, we can add that reasoning here, which could be useful for the viewers in the future. Okay, coming to the investigations. So, comparing diabetes mellitus with diabetic ketoacidosis. Blood glucose greater than 250 in case of TKA, greater than 200 in case of diabetes mellitus. Arterial pH, there is acidosis seen. Bicarbonates, since it is metabolic acidosis, it is low. Ketones are present. Anion gap is high. It's a high anion gap, metabolic acidosis state. Serum sodium, it could be normal or low depending upon the state, as we have seen it here. Hyponatremia. Yeah. Okay, fine. Anyways, it is high, then low after insulin. This is the one for high or low depending upon the therapy. Serum ketone positive. Serum ketone positive, urine ketone positive. Then other investigation and also presence of ketonuria, glucoseuria, ECG monitor peaked T waves, PR prolongation and all that. Serum electrolytes, sodium, potassium bicarbonate and chloride, phosphorus could be assessed. ABG analysis to assess the severity of acidosis. Okay. Blood culture and infection screening if sepsis is suspected. Coming to management, so there is emergency management, insulin therapy, electrolyte correction, monitoring and treatment of underlying causes. So emergency management, airway protection, ensure proper ventilation for unconscious patient because diabetic DKA coma could be a thing. Fluid resuscitation, initial 10 to 20 ml per kg of 0.9% saline bolus over 1 to 2 hours. 1 to 10-20 is 0.9 of normal saline. Ongoing replacement, replace fluids over 48 hours. Potassium replacement 40 milliequivalents per liter after initial resuscitation. So, potassium replacement is also included in the emergency management. And what is the dose? 40 milliequivalents per liter. Insulin therapy, low dose IV insulin infusion 0.1 units per kg per hour. Regular insulin preferred over bolus insulin. Regular over bolus 0.1 units per kg per hour. Continue until pH greater than 7.3 and bicarbonate level greater than 15. So, this is low bolus insulin, low dose insulin 0.1 units per kg and regular over bolus, and do it until this. Electrolytes, potassium replacement start once the urine output is established. So, once you get the urine right, urine output is measured properly, you start with this. Start sodium bicarbonate therapy only in severe acidosis less than 6.9. Okay, that is interesting. Phosphate replacement in severe depletion. So, even that should be measured. So, electrolyte is potassium replacement, sodium bicarbonate therapy and phosphate replacement. Then you have monitoring of vitals, BP, heart rate, temperature, neurological status, watch for signs of cerebral edema, hourly blood glucose checks and serum electrolytes every 2 to 4 hours. Treatment of underlying causes, treat infections if they are present, start empirical antibiotics, psychosocial support and diabetes education. What are the complications? Yes, we have seen this already. Cerebral edema, rapid correction of hyperosmolarity, sodium bicarbonate therapy. Rapid correction of hyperosmolarity. Early symptoms, headache, vomiting, altered consciousness, bradycardia. We have it in the document. Late symptoms, papillary edema because optic nerve and the eyes are the extension of brain. Edema here equals edema here. Human signs, upper motor neuron lesions and respiratory depression. Bradycardia, respiratory depression, altered consciousness, headache, vomiting, papillary edema, human lesions. Human signs. Treatment, mannitol, which is this thing, which osmotically this thing. It is one of the osmotic diuretic. Is mannitol osmotic diuretic? I think it is. Yes, it is osmotic diuretic. It is a very basic question, but due to some reason I just question the fact. Sorry. Urgent CT scan to rule out hemorrhage. Thromboembolism due to dehydration and increased clotting factors. So, why is this the case? Why was thromboembolism a case? Yeah, viscosity due to dehydration and increased clotting factors. Yeah, may be associated with that. Acute gastric dilatation prevented by early rehydration and gastric dilatation. Okay. And then there is hypoglycemia and hypokalemia caused by overcorrection. Okay, post-acidosis therapy and long-term management, subcutaneous SC insulin therapy. Once ketosis is salt. Dietary counseling, high fiber, low glycemic diet. Okay. Daily blood glucose monitoring, fasting, pre-meal, bedtime. Okay. HbA1c, fine, every 3 months, screening for complication. Microvascular, there are some retinopathy, neuropathy, nephropathy. Macrovascular, cerebrovascular disease, PAOD, peripheral vascular disease. And we have covered the complications, we have covered the management, meaning the treatment initial part. We know the laboratory diagnosis and we know the clinical features of juvenile decay. Coming to congenital hypothyroidism, what time is it? Yeah, we have enough time even to go to the next section, which is CNS. Very nice. Yeah, congenital hypothyroidism is the most common hypothyroidism. Sorry. Yeah, it is the most common hypothyroidism seen in children and is a leading preventable cause of mental retardation. Leading preventable cause. So, if it is preventable, better to prevent it in the first place. Clinical features manifest from birth or early infancy. 1 in 3000 live births. Etiology. So, we have different headings: thyroid dysgenesis, dysharmonogenesis, iodine deficiency, pituitary hypothalamic dysfunction, and some syndromes that are associated with these. Thyroid dysgenesis: aplasia, hypoplasia, ectopic thyroid. Exact cause is unknown, but it is genetic and immunological factors, but it is mostly genetic and immunological factors play a role. 98% occurs sporadically, 2% are familiar. Oh, okay. Dysharmonogenesis: inborn errors of thyroid hormone synthesis, autosomal recessive inheritance. Okay, inborn errors of thyroid hormone synthesis. Okay, iodine deficiency in India, I think this is common. Low maternal iodine intake during pregnancy, and severe iodine deficiency leads to endemic cretinism. Pituitary and hypothalamic dysfunction, defective TSH, TRH secretion affecting thyroid hormone synthesis, rare but secondary to leads to secondary or tertiary hypothyroidism. Okay. Associated syndrome, Pendred syndrome, autosomal recessive, sensorineural deafness and goiter is seen. Kosher-Deber, it can't be Debre, it's Deber, I think. Okay. KDS syndrome, I'll call it KDS syndrome. CH, congenital hypothyroidism associated with muscular pseudohypertrophy and especially in calf muscles. So, in calf muscles, muscular pseudohypertrophy. Pathogenesis: thyroid hormones are essential for brain development, growth and metabolism. Deficiency leads to neurodevelopmental delays, impaired myelination, metabolic dysfunction. So, it has roles everywhere, and absence of it or deficiency of it can cause neurodevelopmental delays, impaired myelination and metabolic problems. Untreated CH results in cretinism characterized by growth failure, cognitive deficits and severe mental retardation. What are the clinical features? Early manifestation and late manifestations are could be seen. Early manifestations include hypotonia, floppy baby syndrome, hoarse cry due to laryngeal edema, prolonged jaundice greater than 2 weeks due to bilirubin metabolism, decreased activity and lethargy, wide anterior fontanelle, constipation due to delayed bowel motility. Later manifestations 3 to 6 months, coarse facial features, large protruding tongue which is macroglossia, umbilical hernia, mottled cold dry skin, cutis marmorata, delayed dentition, poor growth, developmental delay and poor feeding. We need to see what this is. Okay, something like this. And we need to see congenital hypothyroidism, how it looks like. Floppy baby, lethargy, coarse skin, umbilical hernia. What else? Hoarse cry, coarse. What was coarse? Coarse facial features, that was a different one. Large protruding tongue, yes, we have seen that. Motor cold rising, we haven't touched it, but we have seen it. Cutis marmota. A delayed dentition, poor growth, developmental delay, poor feeding. Wide anterior frontal. Where is it? Wide anterior frontal. Wide anterior frontal. Yeah. Okay. Diagnosis. Early detection through newborn screening prevents severe complications. So, what are the screening tests? TSH based, where elevated TSH is seen, low free T4 confirms CH. Done after 72 hours after birth to avoid false positive due to transient postnatal TSH surge. Okay. So, postnatal, there is a TSH surge. So, avoid that, we do it after 72 hours. And then imaging studies, ultrasound of thyroid detects absence, ectopic location, hypoplasia. Thyroid scintigraphy, technetium 99 scan differentiates dysgenesis from dysharmonogenesis. Dysgenesis, there is absence of this, and there is less of uptake. There is no uptake or less uptake, but in dysharmonogenesis there is an uptake. But what happens? Yeah, there should be an uptake. What else? How? Maybe there is an uptake. There is uptake here. Yeah, absent or low uptake in case of that. Dysharmonogenesis. Yeah. Diffused increased uptake. Yeah, because of compensated by increasing TSH driven uptake of that. So, okay, same. Okay, the logic works. So, let us save this somewhere. Yes. Coming to other tests, thyroid TBG, low TBG low in TBG deficiency, thyroid binding globulin. Epiphyseal dysgenesis, delayed bone age on X-ray. Of femur and proximal tibia. Differential diagnosis, Down syndrome. Oh yeah, similar. It is similar. Yeah, I thought it looked similar to some other disease. I couldn't actually recall. Down syndrome. Yeah, Down syndrome. Pituitary dwarfism, failure due to GH deficiency, growth failure. Mucopolysaccharidosis, coarse facial features and skeletal abnormalities. What's the treatment? Immediate thyroid replacement. Levothyroxine is the drug of choice. Initial dose 10 to 15 microgram per kg per day should be started. 10 to 15 should be started within first 2 weeks of life to prevent intellectual disability. Monitoring of treatment, and there is thyroid function test at 4 weeks after starting the therapy. 4 weeks after, then T4 TSH monitoring every 3 months, growth and development assessment regularly. Prognosis and follow up, early diagnosis and treatment first few weeks of life to lead to normal intelligence. Late diagnosis lead to variable degrees of intellectual disorders and growth failure. Lifelong therapy is required for permanent congenital hypothyroidism. Transient CH may require. Thyroxine may require thyroxine withdrawal trial at 3 years. So, just to check if everything is working fine, or do you need lifetime thyrosin replacement. Coming to CNS, so it's very nice that we have finished 17 chapters, meaning not exactly, some chapters don't have those many good questions. Coming to CNS, overview of febrile seizures. Febrile seizures are seizures associated with fever. Let me drink some water. Yeah, with fever which is greater than 38 degrees Celsius due to extracranial infection outside cranium occurring in children between 6 months to 5 years. 6 months to 5 years. This is the most common neurological disorders, children affecting 3 to 5% of the population, meaning in this particular age group. Median age of onset is 18 to 22 months and it is exclusively seen in children. Definition: febrile seizure defined as seizure associated with fever. It is associated with fever occurring in children between 6 months. Sorry about this again. Yeah, 6 months to 5 without any underlying CNS infection. So, without any underlying CNS infection, metabolic imbalance or history of afebrile seizures. So, there is no CNS infection, no underlying CNS infection, metabolic imbalance or history of afebrile seizures, and there is an association of fever with seizure with fever. Etiology, risk factors. Etiology, genetic factors, there is familial disorder, positive history, family history in 1/3 of the cases, autosomal dominant inheritance, and there is FS genes. There are two genes, FS1, FS2, and the first one it is located on 8q and next one at FS2 present on 19p, sodium channel SCN1A. Is that important? I doubt they go in such great depth, but anything can come in MCQs, but I doubt we need to worry about that. Anyways, FS1, FS2, 8q, 19p. Yeah. Pathogenesis, exact mechanism is not well understood, possibly age dependent. Immature brain is more susceptible to febrile illness. So, fever if it is there, and if you are a small baby, you have a high chance of seizures. That is what this sentence means. You are more susceptible to seizures. Yeah. Possible etiologies, infections and immunization related. Infection, acute otitis media, dysentery, viral fever. So, here we have some risk factors, major and minor. So, first we will look at the major criteria. Age less than 1 year. Yes, we have seen immature brain. Seizure within 24 hours of fever. So, most likely associated. Fever 38 to 39 degrees during seizure. Uncertain home situation. First episode. Then there are minor criteria, family history of febrile seizures or epilepsy, complex febrile seizures. Is it? Yeah, we have complex febrile seizures, daycare attendance, male sex and hyponatremia. So, these are minor criteria which you can write in the answers. Then minor risk factors, criteria and risk factors. Risk factors for future epilepsy, seizure within 1 hour of fever onset. So, you have fever right now, the baby has fever, the child has fever, and within 1 hour there is seizure, fever, then within 1 hour seizure. Family history of epilepsy. Focal seizures, impaired neurodevelopment. Focal seizure, impaired neurodevelopment. And simple febrile seizure and minor risk factors and recurrent febrile seizures. Types, there are 3 main types. simple which are typical febrile seizures, complex which are atypical, febrile status epilepticus. First one 6 months to 6 years, 6 to 6, generalized tonic-clonic type, duration less than 15 minutes, recurrence, no recurrence within 24 hours, no post-ictal neurological abnormality, which is all fine because it is simple. Generalized tonic-clonic less than 15 minutes, 6 to 6, no recurrence within a day, no post-ictal neurological abnormality. Then complex febrile seizures less than 5 months, greater. So, this one is this, below this, above this is complex, focal or focal to generalized, focal or focal to generalized, duration greater than 15 minutes, multiple episodes within 24 hours, no recurrence within 24 hours, multiple episodes. So, this becomes complex, associated with post-ictal neurological abnormality. So, complex febrile comes under minor this thing for febrile seizures. Then febrile status epilepticus, seizure lasting for greater than 30 minutes. So, here it was greater than 15, here it is greater than 30. One prolonged or a series of seizures without regaining consciousness. One prolonged or a series of seizures without period of recovery in the middle. High risk of developing epilepsy. Clinical features, generalized tonic-clonic seizures are most common. In infants, rolling up of eyes, fixed gaze, tonic movements. Some may have myoclonic jerks. So, myoclonic jerks only in some conditions. Focal seizures may occur but require further evaluation. So, focal seizures, where did we see? Here, complex, otherwise it is generalized tonic-clonic. Focal, next one, no signs of CNS infection or metabolic disorder, which forms the definition of this particular case condition. Investigations, in typical, no need of neuroimaging or lumbar puncture. In atypical, lumbar puncture if less than 6 months, okay. Toxic child with high fever, clinical suspicion of intracranial infection. Age 6 to 12 months if Haemophilus influenza B or pneumococcal vaccination is incomplete. Age 6 to 12 months. So, normally it is 6 months, less than 6 months for lumbar puncture, but if you do not have the vaccination right, you do it between 6 to 12 months too. EEG if risk of recurrence or future epilepsy. To identify the cause of fever, hemogram, ESR, blood and urine culture, serum electrolytes, blood glucose, calcium, magnesium, so all electrolytes. So, ESR, CRP, ESR hemogram, blood and urine culture to check for any kind of toxic sepsis like state, electrolyte levels, neuroimaging if focal seizures, focal seizure or persistent neurological deficits. Coming to the management, the treatment of these seizures, immediate management, long-term management, because there is a tendency, right, epilepsy, recurrence. So, active seizures, IV or rectal diazepam 0.3 milligram per kg per dose, 0.3 milligram per kg per dose. If seizures persist, IV or nasal midazolam 0.1 to 0.2 milligram per kg. Other options, IV lorazepam, rectal clonazepam, IV or rectal diazepam 0.3 mg per, so 0.1, 0.2 comes like this, but some way to remember. First one diazepam, second one is midazolam, third one IV lorazepam, next one rectal clonazepam. Long term management, goal to prevent recurrence, that is what, and evaluate for epilepsy risk. Low risk cases, no treatment or further investigation. High risk cases, we do. So, high risk, here we have high risk. Major risk factors can see focal seizure, impaired neurodevelopment, family history, within 1 hour of onset. So, in those particular conditions, neuroimaging, EEG, intermittent diazepam prophylaxis, parental education on recognizing and managing febrile seizures. Intermittent diazepam prophylaxis, which is mentioned here, given during febrile episodes, 0.3 mg per kg per dose, 8 to 12 hours. Every 8 to 12 hours, a fever greater than 38 degrees Celsius. Antipyretic measures reduces fever but does not prevent seizures. Avoid sponge bathing. It triggers shivering, increases metabolic demand. So, avoid this. Anti-epileptic therapy not required for simple febrile seizures. So, this was what for. So, most of the risk factors, high risk factors were mainly similar to the things that were seen in complex atypical type. So, it is not required for simple febrile. Prognosis, most are benign and resolved by 6 months, 6 years of age. Recurrence risk is very high in case of complex. That is why we need anti-epileptic prophylaxis. Therapy or prophylaxis? Wait a second. Anti-epileptic therapy, on a long term basis. It's prophylaxis. Next, coming to status epilepticus. The only thing is this thing, such huge thing. Anyways, it's very important. It came up during our last model exams and I couldn't remember the dose again. But this time we will make sure that we remember it. Status epilepticus defined as seizures lasting for more than 30 minutes. Seizure lasting for more than 30 minutes. So, or recurrent seizures lasting for more than 30 minutes without recovery of consciousness in between the attacks. Without recovery of consciousness between the attacks. So, continuous more than 30 minutes, or if it is lasting for more than 30 minutes without recovery of consciousness. There is recurrent seizures, but no in the middle you don't have regaining of consciousness, recovery of consciousness, sorry. This condition is neurological emergency requiring immediate intervention to prevent permanent brain damage. What is the incidence? 50 per 1 lakh, children less than 3 years, most common. So, what are the types? So, generalized tonic clonic. So, based on seizure type, generalized tonic clonic, partial, absent. Based on clinical presentation, convulsive, status epilepticus, non-convulsive type. So, convulsive, there is tonic clonic, myoclonic, most common and life threatening, and non-convulsive there is absence or complex partial seizures. Absence or complex partial, difficult to diagnose, may present as altered consciousness. So, this is another way of classifying it compared to this convulsive, non-convulsive, tonic clonic, myoclonic type, and this one life threatening, and the other one is absent and complex partial types. And etiology, infections. So, viral infections, viral encephalitis, pyogenic tubercular meningitis, neurocystic sarcosis, this one tapeworm. Metabolic disorders, hypoglycemia, all hypos, hypomagnesemia, not kalemia, not hypokalemia, glycemia, calcemia, natremia, magnesemia. Vascular events, stroke, thrombosis, embolism, hemorrhage. Stroke, thrombosis, embolism, hemorrhage. So, affecting the brain, right? Toxic and drug related, drug toxicity, withdrawal of anti-epileptics. And the others, hypoxia, anoxia, head trauma. What are the precipitating factors? Fever or febrile illness. missed anti-epileptic, in case the person is known to have these seizures. I will just finish this part because even I am feeling sleepy right now. I will just finish this. Yeah, and missed, yeah, sleep deprivation. I want to sleep. Yeah, missed anti-epileptic drugs, sleep deprivation, emotional stress, fatigue, and CNS stimulation. So, all these are the precipitating factors: fever, febrile illness, missed anti-epileptic drugs, and sudden withdrawal can cause the episode. Sleep deprivation, emotional stress, fatigue, CNS stimulants like theophylline can lead to this one. What is it? Status epilepticus. So, with that we end this session for today, but the next session we would be starting with the pathogenesis of status epilepticus, and we will cover the entire CNS most likely, and then we will go on to the next one. Hopefully, I remember to add the answer to this. This one would be fine actually, and the rest of it would be, not sure how long it would take, but CNS would be done by the next session. Okay then, yeah, so I will link this document under this YouTube channel, under this YouTube video, and in case you would like to go through it, you can go through it. And yeah, so in case you like this particular discussion, should I call it a discussion? I am not sure, but in case you like this video, you can like it, and in case you have any suggestions, you can write it in the comments. In case you have any other suggestions which you can't write here, you can write it in the Instagram DMs, and I will make sure to respond. But currently it is Insta and YouTube are both are very low engagement, so let us see how that goes. But anyways, that's all for today, and I need to go. Okay, bye bye.